Hello and welcome. You found the Social Work Podcast. My name's Jonathan Singer, and I'll be your host as we explore all things social work. Today's podcast is the first in a two-part series on clinical hypnosis. Today I speak with Dr. Elizabeth Winter about the history of clinical hypnosis, key assumptions, goals, the client's role, and the types of problems that might be addressed with clinical hypnosis. In the second episode, I talk with Dr. Winter about how and when to use clinical hypnosis. Before I was a social worker, the image that would pop to mind when I thought of hypnosis was of somebody walking around, clucking like a chicken, or someone thinking that he or she was a cucumber. I thought that hypnosis had to do with someone taking over my mind, making me do things I didn't want to do. Well, this image, this concept of hypnosis has, of course, been perpetuated by cartoons, movies, and, comedy circuit hypnotists. In fact, being in a hypnotic state has nothing to do with giving up control and everything to do with choosing to enter a state of deep relaxation. In today's interview, Dr. Winter talks specifically about clinical hypnosis, the kind of hypnosis that you might encounter in a therapy session. However, hypnosis has applications beyond the therapy room. A study published in the September 2000 Journal of the National Cancer Institute supports the use of hypnosis with breast cancer surgery patients. Now, I think this is really interesting because it provides some empirical support for the use of hypnosis, that is, deep relaxation, for medical rather than psychological treatment. So listen to this. The authors, Guy Montgomery and his colleagues, they divided 200 patients who were receiving the same surgery into two groups. One group received a 15-minute pre-operative hypnosis session. The other group received a session where someone listened empathically to their concerns. The authors found that compared to those that received the empathic listening, the hypnosis group reported significantly reduced post-operative use of pain medications, reports of pain, nausea, fatigue, discomfort, emotional upset at discharge, and really interestingly, reduced institutional cost. Again, this study provides some empirical support for the use of hypnosis in a medical setting. Now, for more information about this study and links to other information about hypnosis, specifically clinical hypnosis, you can go to the Social Work Podcast website at socialworkpodcast.com. And now, on to the interview with Dr. Winter and clinical hypnosis. Dr. Winter, thank you for joining us today. I'm really looking forward to talking about clinical hypnosis. I was wondering if first you could give us a brief overview of the history of clinical hypnosis, including perhaps some of the key figures in its development.
Certainly. Clinical hypnosis started really in the 19th century when the term was coined by a physician called James Braid, who had observed exhibitions of what was then known as mesmerism or animal magnetism. And Braid thought that rather than a magnetic force of any kind, he thought that this was suggestibility and a form of sleep, so he then called it hypnosis after the Greek word hypnos for sleep. Hypnosis was used for anesthesia and analgesia by a surgeon by the name of Esdale in India, where he had used this on Indian patients in need of surgery and was very successful in reducing what were then very, very high mortality rates. With the advent of ether, hypnosis became something that was a skill that had to be learned rather than a chemical that could be applied and became less popular. It was used later in the 19th century by some of the big names in psychotherapy at the time, such as Charcot and Genet, Joseph Breuer, and Freud, of course. Freud had an early interest in hypnosis, which gave way really as he developed psychoanalysis. And so hypnosis sort of waned in popularity again. Probably the main name from the 20th century was Milton Erickson, and we still have the Erickson Foundation and what's often thought of as the Ericksonian methods of hypnosis and hypnotherapy.
What are some of the key assumptions of clinical hypnosis?
There are a number of things to consider here. One is that trance, or a hypnotic state, is usually conceptualized as highly focused attention, so that a person in trance is very highly focused on a certain thing and conversely defocused on other things. So it's a very tightly focused attention on the inward rather than the outward. Not exclusively, but certainly probably most commonly. What it is not is perhaps also extremely important. It isn't sleep, as we said earlier. It isn't a form of mind control, which is, perhaps how it's popularly portrayed in terms of stage hypnosis. So it really does need to be distinguished from hypnosis as a form of entertainment. A person who's going to be working with hypnosis clinically really needs to be, I think, well trained in the use of that. So perhaps one of the assumptions, if you like, is that the person doing this has had appropriate training. Other assumptions are that a trance state enables a person to perhaps address both their mind and their body at the same time. People may have come across this phrase before, is that every psychological event is a physical event and every physical event is a psychological event. So it's never one thing or the other. We perhaps have a slightly dualistic concept of the mind and the body, but working in trance really tends to draw on the idea of a holistic single thing. Again, one of the ways I think of that is that you can look into a building through one window and see a particular view, and you can look into a building from another window and see another view, but it's the same building, it's the same contents. Other assumptions would be that, obviously, the obvious things like informed consent and so on and so forth. So, the same kinds of assumptions that you would have for any form of treatment.
So it sounds like one of the main assumptions of clinical hypnosis is that it is an internal focusing, possibly to the exclusion of the external world, and that there is an understanding of the mind and the body as a gestalt.
I think that's right, and I think that I'd also add that there's an assumption that trance is a naturally occurring phenomenon. In other words, when you use it clinically, you're intentionally using something that we all know how to do anyway. And to give you an example of that, if you have ever watched a young child glued to a television set or a computer screen, to the exclusion of all else, they're not perhaps focused internally, but they are very, very tightly focused on that thing. And you can talk to them sometimes for quite some time, and they have absolutely no idea you're there. Not because their ears don't work, but because they have defocused on that particular form of input. So that, if you like, is a naturally occurring trance state. Likewise, if you've ever driven home and completely spaced the drive, and you knew where you were going, but you have no recollection of having got there, chances are that was a naturally occurring, what's often called the driving trance. It is a naturally occurring thing. The difference when you're using it clinically is that you have an agenda. So you have a therapeutic intention and an agenda for that trance. And if you can enter trance spontaneously, then you can enter it intentionally. And that's also, I think, an assumption of practice. For research purposes, people often use hypnotizability scales, which will show that some people are more hypnotizable than others. And that can be tremendously useful for research work. From a clinical practice perspective, most people who work with this particular skill will make the assumption that if someone can go into trance naturalistically or naturally, if you like, then they can do it intentionally.
Is clinical hypnosis a standalone treatment, or is it something that can be used in conjunction with other forms of treatment, such as behavior therapy or solution-focused treatment?
Hypnotherapy is not a treatment per se. It really is a skill or a tool. It's a sort of a scalpel, if you like. It's analogous to that. So does it stand alone? Well, not really. It depends what you want to do with it. So you can use trance work or hypnosis as part of cognitive behavioral therapy, as part of psychodynamic therapy, as part of couples therapy, individual, group, self-management. I mean, you can really use it in a variety of different ways. So no, it's not a standalone. in my estimation, best used as part of an ongoing, planned psychotherapeutic intervention. People will often say, well, can you just teach me how to go into trance so I can stop smoking? Well, yes, you can absolutely teach it as a skill, and it's certainly my preference to teach it as a skill that someone takes away with them rather than something that the clinician does to them. But it's not going to be something that will stand alone without looking at why, if someone wants it for habit cessation, why do they smoke? What's the context of that? Obviously, it's not a magic solution, but used within an appropriate course of treatment, then yes, a very useful tool.
What is the role of the client when the clinician is using hypnosis?
That's really an interesting question, and I think it depends as much on the discipline of the clinician in question as it does on anything else. Clinical hypnosis is used by really a broad variety of folks. So that may be social workers, it may be psychologists, it may also be dentists, physicians, chiropractors, nurses. So how the client's role is conceptualized is really as much a function of whether and to whom they're presenting for service as it is of hypnosis itself. So I'm speaking personally as a social worker, I will usually be working with someone on the basis of using hypnosis as a personal skill. For example, typically in a first session with someone who specifically wants to learn hypnosis, we will do some trance work in that first session with the goal that this person can then induce trance for themselves, whether or not I happen to be there. So it really, for me, is something that it's a skill that someone takes away, not something that they have to come to me to get.
So it sounds like the client's role differs based on the setting. So if I was a patient in a dentist's office, it would be different than if I was in a psychotherapy office. I
think that's right, and I think that as we talk more about how it's used, I think perhaps that'll become clearer too. I'm thinking of people that I've worked with over the years, some of whom practice it and practice a great deal, and because it's a skill, practice is important, and so they have sort of taken it as their own and do what they need to do with it. And I'm thinking that there are other people who use it more rarely, but will come in and say, I'm having trouble with this. Could we do some trance work around this particular thing? One example that comes to mind is somebody who was getting some quite distressing physical discomfort and couldn't work out whether this was stress-related or not. Well, of course, as a social worker, the first thing you do is send someone to get a full medical workup. But in terms of preparation for that workup, one of the things that we did was to have this person go into trance, and they were very good at that. They'd done it many times, and to do what you might call a full body scan. What was paining them? How was it paining them? What was the quality of that? So that when they went for their medical workup, they could really give some high quality information to the physician. And also be a little calmer in themselves about knowing what was going on for themselves.
What are some other types of problems that can be addressed using clinical hypnosis?
Well, if we look at that in a very general way, those are going to fall into the more medical kinds of things, and then what we would think of as the more psychosocial kinds of areas. Hypnosis certainly can be used both with adults and with children, and actually, since children, their natural ability to go into trance is really, really high until we train them not to. So they are very, very susceptible and very comfortable going into trance. And there's a lot of medical work done with kids around pain control and prepare children for procedures, particularly painful procedures. Karen Allness actually has written a very, very nice book and done a great deal of work on working with children in medical settings using hypnosis. Obviously, pain control or shifting perceptions of pain is certainly a way to use hypnosis. And there's a fair amount of evidence actually looking at using hypnosis to reduce the need for analgesic medication post-operatively, to reduce subjective perception of pain, and to decrease wound healing time also. Some quite nice evidence out there for that.
I also know that hypnosis is used in birthing. There's a whole area called hypnobirthing. And in hypnobirthing, they reconceptualize pain as pressure and suggest that if you're in a state of deep relaxation, you won't be fighting your body's natural process. So the idea is that the fight is what causes the pain. And hypnobirthing points to cultures where the birth experience is not discussed in terms of pain, like it is in the United States. Interestingly, this approach seems to be very different than other birthing classes like Bradley or Lamaze, even though those classes include basic hypnotic techniques like breathing for relaxation.
Interestingly, Lamaze was trained in hypnosis, so there's probably some very strong links between what Lamaze did around childbirth and his training in hypnosis, as I understand it. But yes, certainly that's a very nice cognitive intervention to reconceptualize pain as something that is not pathological, but quite appropriate for the process. And there's, again, a lot of folks working with childbirth preparation with hypnosis. So to help somebody to understand what to expect, and again, going back to that assumption that you're not just talking to the mind, you're talking to the body. So one of your suggestions may be that as you feel a certain kind of pressure, then that will be your cue to allow that muscle to relax and lengthen, or the ligament to soften and lengthen and do what it needs to do in the childbirth process. So that would be a very nice example. In the sort of psychotherapeutic world, hypnosis is used in a number of different ways. Anxiety, and of course that could well be related to. It could be related to anything at all. I mean, I'm thinking of your example of childbirth. So you would deal perhaps not only with the physical sensations of that, but also fear of pain, fear of the process, whatever the process is. So anxiety, certainly. Depression, ADHD, actually, there's some use of that in terms of filtering input. If you consider hypnosis again as a state of highly focused attention, and if you think of attention deficit disorders as the inability to not focus, then something that would help somebody filter input could be very, very helpful. Addictions as a skill in terms of perhaps understanding and identifying some of the triggers for addictions, and also in dealing with cravings when they arise. There are some very good applications there, and then some really general things like general ego strengthening, general relaxation, stress reduction. And actually, I tend to use hypnosis for folks who have post-traumatic symptoms, helping people to find a way to ground and to deal with some of the physiological anxiety symptoms that really hit people hard in post-traumatic stress disorder.
It sounds like a wide variety of issues that can be addressed with clinical hypnosis. And it sounds like with the examples that you gave, there's similarities, but they're really targeted to whatever the most distressing symptom is. So with the ADHD, it would be attention. With the childbirth, it might be, what does this pain mean? What is this triggering? What is this telling you to do at this point, as opposed to, oh my God, make it stop.
Right. And what you're dealing with is our ability to focus. So whatever one focuses on or chooses not to focus on, that's why it's a wide variety, because focus itself can be applied to absolutely anything. I think it's also important to add that, contrary to the misconception that hypnosis reduces somebody's control or is control over the person that you're working with, the goal, if you like, of many uses of trance is to increase control, so that somebody has more control over emotional responses, over physiological processes, and can, again, given the childbirth example, feel more control in what is happening in that particular process. So control over levels of perceived pain, control over how long something appears to take. There's a concept in hypnosis called time distortion, and if you think about being a kid on the last afternoon of the last day of school before summer vacation, how long does that afternoon stretch out? Subjectively, for a kid, it's forever. Now, if you want to make something last longer, that's great. You then might cue somebody to recall that kind of long, long time. If you're dealing with something like discomfort or pain, then you might want to do the opposite and talk about how quickly time can pass. So that our ability to experience time in this very subjective way is something that we can use in a trance state to have some control over procedures. And some of the procedures that, things that involve like bone marrow procedures and so on, where there's a high degree of discomfort, and to use trance to sort of go away and change the length of time that seems to take can be very, very helpful to people. But the whole idea of this is to have more control over what's happening. So for anxiety, for example, the control that one might like to have is control over some of the physiological aspects of anxiety. Things like reducing your heart rate, calming your breathing down. And when you do that, then your subjective experience of anxiety changes, because you've dealt with some of the physiological things that are part of it, and that then feed that whole process of becoming anxious and maintaining an anxious state. So it really is about putting control, giving control to the person who is learning to do this, and again, importantly, taking that away out of the office so they can do it as and when they need to or want to.
This concludes the first part of our 2-episode series on clinical hypnosis. In today's podcast, Dr. Winter and I talked about the history of clinical hypnosis, key assumptions, goals, the client's role, and types of problems that might be addressed with clinical hypnosis. Please join us for part 2, when Dr. Winter and I will talk about how and when to use clinical hypnosis. So, I'm Jonathan Singer. Thanks for being with me today for this episode of the Social Work Podcast. If you missed an episode, visit our website at socialworkpodcast.com. If you have suggestions